Hello guys, this is Dr. Piri. So I hope you had time to check the part A of lecture 6, blood physiology. So this is a part B of lecture 6, blood physiology. So if you remember very well, in part A of this lecture, we looked at leukopoiesis, the production of white blood cells, and we also looked at the general functions of white blood cells, and then went into detail to look at the specific functions of each white blood cell. So this part B of lecture 6, blood physiology, we are going to simply look at total white blood cell count. So in the lab, what can you do to count these white blood cells? So there is a total white blood cell count that you're supposed to do in the lab, but deliberately I just added this slide so that you can appreciate, because right now, in this era of COVID-19, we are not having labs apparently, so it means we just have to add some more information for you to appreciate, so that when we do the actual thing in the lab, it will become very easy because you have the information at hand. So after doing the total white blood cell count, we'll also look at differential white blood cells. So differential white blood cell count. So there is total white blood cell count, whereby you're just counting the number of white blood cell without differentiating them. Then you can also do a differential white blood cell count, where you're going to differentiate the 5 different types of white blood cells. So you need to count how many are neutrophils, how many are lymphocytes, how many are xenophils, basophils, and monocytes. So you're doing a differential white blood cell count that is done on blood smear using a microscope. So I'm going to discuss with you guys that, and then towards the end of this part B of lecture 6, we are going to discuss disorders associated with white blood cell. So what kind of disorders are due to the dysfunction or malfunction of white blood cell, or maybe these diseases that will result into overproduction or underproduction of these white blood cells. So look at different types of leukemia. Then we'll also look at white blood cell production, underproduction, or overproduction in general. So we'll discuss that. But you need to bear in mind that this is physiology, so you don't have to go deep into the pathology. So I'll be highlighting certain things for you to appreciate in physiology. But we know to say you're going to cover these topics in pathology as well, also in hematology. So the diseases won't waste much time. So now let's start by looking at total white blood cell count. This is just a normal procedure that is done in labs. So in general, you know to say that the white blood cells are larger than red blood cells. So in terms of size, they are larger than erythrocytes, and they also contain a nucleus and do not contain hemoglobin. White blood cells, they do have a nucleus. Red blood cells, they don't have a nucleus. So a mature red blood cell, we say that there is a stage where it's going to lose the nucleus. So there is ejection of cyanotic nucleus. Then it will become a reticulocyte, and then the reticulocyte can mature into a red blood cell. White blood cells, they don't lose a nucleus. So they will maintain the nucleus within them. So even as you're looking at these cells under microscope, you still appreciate the nucleus. And then on top of that, they don't have hemoglobin. So they are not involved in transportation of oxygen, carbon dioxide, all that kind of stuff. So here, white blood cells, they are mainly involved in immunity. So we're going to discuss the functions. We've already discussed the functions of white blood cells. So by now, you know what I'm talking about. So they are involved in immunity. In terms of normal count, so the total white blood cell, depending on the textbook you're using here again, so the normal range should be 4,000 to 11,000 cells per cubic millimeter of blood, or per microliter of blood. So you should have about 4,000 to 11,000 white blood cells per cubic millimeter of blood. But certain textbooks will give you a different range, maybe from 5,000 to 10,000. So never mind, because all the recommended textbooks that I've given you, if you use any information from those, I'll be able to know which textbook you're using. So you're all covered. But you need to realize that the majority of healthy adults, the range is restricted within 6,000 to 900 cells per cubic millimeter of blood. So in adult, normal adult, you find that the normal range of white blood cells should be between 6,000 to 9,000 white blood cells per cubic millimeter of blood. But depending on the size, the shape, the appearance, you have different types of white blood cells. So you have granulocytes and granulocytes. Granulocytes without the granules, we've already discussed that. So we have two types of granulocytes, monocytes and lymphocytes. The granulocytes, you have three types: neutrophil, basophils, and eosinophils. So those are different types of white blood cells. But now when you're looking at them under microscope, how are you going to count them and how are you going to identify them? So there is a manual method of counting white blood cells. So this manual method of counting white blood cells is the same hematocytometer. So you have hemocytometer. The hemocytometer is a special type of slide. So this is called improved Newbar chamber slide. It's the same slide that we use when we're looking at red blood cell count. So remember, when you're looking at total red blood cell count, we also use the improved Newbar chamber, but there were different squares where we are counting from. So for the red blood cell, we say that we concentrate on the larger square at the center of the other squares. Remember, when you're looking at this portion where you do the recording of white blood cell and red blood cell, there are about 9 bigger squares. In those 9 bigger squares, the one at the center is different because inside it has got about 25 smaller squares. Then the squares at the corners and the one at the center, that's the squares you count for red blood cell. But for white blood cell, you consider the bigger squares on the corners. So you have the 4 bigger squares on the corners of the 9 squares. So those are the ones that you concentrate on white blood cells. So I'll explain even if you don't understand. So even here, you also need some equipment for you to do a total white blood cell count. So what kind of equipment do you need? So you need white blood cell count diluting fluid. So you need the diluting fluid, and then you also need white blood cell pipette. Remember, there are 2 types of pipette that is found within the hemocytometer. So you have red blood cell pipette and white blood cell pipette. And I already explained how you can differentiate the 2. So I won't waste time trying to explain that. But here now, we're going to use a white blood cell pipette with a white bead inside, with a white mouthpiece. And then it has got a different calibration. Here it has got a calibration of 0.5 mark, and then 1.0 mark, and 101 mark, or 11 mark for white blood cell count. For the red blood cell, it's the one that will have 101 mark. Okay, so those are just some minor differences. So these are the equipment that you need. So you also need the hemocytometer and the cover slip. So you have a hemocytometer, a cover slip, a microscope, of course, a lint-free wipe, alcohol pads, or alcohol-based swabs that you can use. And this is the white blood cell pipette that you're going to use. So you can see the mark here, 0.5 mark, 1 mark, and 11 mark. Then inside here, you have a white bead. So the actual procedure, okay, I lost connectivity. Okay, sorry about that. So we proceed. So in the lab, what exactly do you do for you to do a total white blood cell count? So this is just a procedure. So using the micropipette with a white bead inside, so you can see the micropipette with a white bead inside, you suck the capillary blood up to the mark of 0.5. So this is the mark. So you just suck your blood sample up to this mark, 0.5. Then after that, you suck the Dentian violet solution or the GIMSA up to the mark of 11. So you can see 11 mark here. So you suck all the way up to this mark, 11 for white blood cells. When you do that, you'll have made the dilution of 20. So the dilution factor here is 20. You are mixing about 0.5 into 10 parts of the diluting fluid. So 10 divided by 0.5, it will give you about 20. So that's the dilution factor. So now when you do this, how are you going to count the cells? So after making your dilution here, then you need to discard the first 2 drops, so you can use a cotton swab just to get rid of the first 2 drops, so that when you're charging into the new blood chamber, you introduce the blood that has been thoroughly diluted with the diluting fluid. So there are squares in which you're going to count white blood cells. So like I said, you consider the 4 major squares at the corners for white blood cells. And these are different because inside them, they have 16 smaller squares. So when you're counting the white blood cells, you're counting in those squares. So since there are 16 in each, if you say 16 multiplied by 4, it will give you about 64 smaller squares where you're going to count the white blood cells. So this is what I mean. Okay, so on the new bar slide, so you can see the plus sign here. This is where you count the red blood cell. Like I said, there are 4 small squares inside. Out of the 25 small squares, you only count on these squares for white blood cells. So that was done. For red blood cell, that was done. But for white blood cells, you count these squares on the corners. So you can see 1, 2, 3, 4 squares. That's for white blood cells. So these squares are different from the one at the center. Why? It's because at the center, we say that this bigger square has got about 25 small squares, but these bigger squares for white blood cells, they have only about 16 small squares inside. How you count is also the same like we did for red blood cell, whereby you count the cells that are touching the triple lines of the top. So you have triple lines here, 3 lines, and those cells that are touching the middle line, you count them. And also on the left side or left margin, you also count those cells that are touching the middle margin. Then you count all the cells within this square. And then you go here, you do the same. So as you're counting, you can start from this small square. Then you go like that, counting, you come down, you count all the way until you count all the 16 squares. Then you move on to another square. So you do the counting just like that. Then you get the average of what you'll have counted in the 4 squares. So what you do is you add the cells that you've counted here, in this square, in that square, and in that square. Then you divide by 4. So now it will bring us to how you can calculate this. So how do you calculate after counting? So for instance, here you counted, maybe let's say you have counted, let's say 50 cells, and then even here 50 cells, and then here you've counted 25, even here 25. So you'll have a total of 150 cells, white blood cell that will have counted from the 4 boxes. So how do you do your calculations? So this is the formula for calculating white blood cells, total white blood cell counts. So you can see here, total white blood cell counts formula is equal to number of cells that you will have counted in the 4 bigger squares, or you can say 64 small squares, because in each bigger square you have 16 small squares. Then you divide that by 4, meaning that you're just getting the average number of the cells that you have counted in the 4 squares. What's the average number? That's why you're dividing by 4. Then you multiply that with dilution number. Then you multiply by the reciprocal of the chamber depth. So the dilution number, we say that you are mixing 0.5 of blood into 10 parts of the diluting fluid. So the dilution factor or number is 20. The depth of the chamber is 1/10 millimeter. So if you say number of cells that you have counted in all the 4 squares, divided by 4, multiplied by 20 times 10. So for instance, if we say you counted about 150 cells, let's say you counted 150 white blood cells in all the squares. So how do you do your calculations? So it's very simple. So what you're going to do is 150 cells here, divide by 4 to give you 37.5. That 37.5 multiplied by 20 to give you 750 multiplied by 10. So it will give you 7,500. So it means you will have counted 7,500 cells in these 4 squares. So, I mean, the total number of cells before dilution, because you factored in the dilution factor and also the depth, the reciprocal of the chamber depth. So with all these factors, it means per microliter of blood, you'll have counted 7,500 cells. So this total red blood cell count now, it will become 7,500 white blood cells per cubic millimeter of cells, or per microliter of blood. So because we're talking about per cubic millimeter of blood or per microliter of blood, then you compare that to the normal range. So I told you the normal range is between 4,000 to 11,000. So 7,500 is within the normal range. So you find that you have normal total white blood cell count for this particular person. But sometimes they can give you condition whereby it will be less than the normal range or it will be more than the normal range. So you need to pay attention to that. Moving on to differential white blood cell counts. So differential white blood cell counts. So here you're interested in different types of white blood cell counts. So you want to come up with a leukogram. A leukogram, you want to quantify how many neutrophils, how many monocytes, how many basophils, how many eosinophils, and how many lymphocytes. So you're going to do a differential white blood cell count. You want to differentiate the different types of cells. So you're going to make a special slide, which is called a smear. And this smear, you're going to count about 100 cells. Out of those 100 cells, you need to know how many were neutrophils, how many were basophils, just like that. So you're talking about differential white blood cell count. So let's start. So you need to collect your blood sample. So you can collect your blood sample from different sources. So there are 3 different sources where you can get your blood sample for differential white blood cell count. So you can have the capillary blood, you can use venous blood or arterial blood. So it's very simple. Then you also need a microscope for you to do a differential white blood cell count, but you need to use different magnification now since you want to differentiate the actual cells. So first, when you get your microscope and then you get your blood sample, you make a blood smear. After making a blood smear, you mount the slide on the microscope and then you start focusing the microscope. So you can start with the magnification of 10, the magnification of 4. So by 4 to see the general formation of the slide. So just want to appreciate the slide. So you can use the low power there, the times 4 magnification. And then after that, you can use times 10 magnification for counting white blood cells. So if you just want to do the white blood cell count, you can use magnification of 10. But if you want to do the differential white blood cell count, then you also need an extra oil immersion. So you have oil immersion. So this oil immersion, you just put a drop of this oil immersion, and then it will help you to differentiate the cells. So now with your oil immersion on the blood smear, then you need to use a magnification of times 100. So because now you need to differentiate the different types of cells. So when you're looking at the neurocytes, you need to differentiate the types of granules that are found within these cells so that you're able to tell whether it's a neutrophil, basophil, or xenophil. So you need to have a higher magnification power of by 100 so that you're able to appreciate the cells. So you expand the cells 100 times the normal size in terms of magnification so that you're able to differentiate these different types of white blood cells for you to do a differential white blood cell count. So this is how you make a smear, which you do maybe in hematology. So you get your blood sample. So you put a drop of blood sample on the slide. So let's say you put it here, just a drop of blood sample on this slide. Then you use a cover slip or another slide. Then you just spread the blood. So you're making a smear. It's a special type of movement that you're supposed to do as you are making this smear so that you are able to form the head of the smear, the body, and the tail. So the head, this is why you put a drop. So it means that the concentration of cells here are greater. So cells are not spaced very well here. It's very difficult for you to do differential white blood cell count here. Why? It's because you have cells that are stacking to one another. So it's very difficult to do a count here. But within the body, you can see that the cells are spaced, and then you can do your count. When you're looking at the tail, the concentration of the cells here are even less, so you find that they are more spaced cells. So the best location for you to do a differential white blood cell count is the junction between the tail and the body. So somewhere here, the junction between the tail and the body, this is where you do your differential white blood cell count. So it will allow you to do a differential white cell count twice because these cells are separated. So you're able to differentiate them and to appreciate them. So how do you do that? So now you're still within that junction between the body and the tail. So the tail is somewhere here, the body is somewhere this side. So you're starting from here. This is the junction I'm talking about. So you go downwards, differentiating the types of white blood cell you're finding there and counting. Then you go upwards, just like that, downwards, upwards, just like that. Then you record the different types of white blood cells. So you can see here the different types of white blood cells. You can see that this one looks like a neutrophil with segmented nucleus. There are about 4 lobes in this cell. Then you can also appreciate this one, which looks like an xenophil, 3 lobes. Then you can also appreciate the granules. So at this power, it's very difficult for you to differentiate them. But when you're using the magnification of 100, it will be very clear for you to appreciate these cells. So use the magnification of by 100. Okay, then as you are counting, sometimes it's very difficult for you to remember how many you counted lymphocytes, how many you counted eosinophils. So there is a special machine, simple machine that can help you to record that. So as you are going down the slide, as you are counting on the junction between the head and the tail, you are able to know the types of cells. So let's say L is for lymphocytes, P is for neutrophil, M is for monocytes, E is for xenophil, B is for basophil. So you can see you have L, P, 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 L, P, P. So as you are recording an L, you just press where there's L. So you have this simple machine with the labels for all the types of white blood cells. So you have neutrophils, lymphocytes, eosinophils, basophils, monocytes, just like that. So as you are counting, you don't need to count them. When you see one, you just press where there is P or where there is L. Then at the end of it, when you have the total number of 100 cells that you have counted, then you can do your leukogram. So you know to say how many P's from this now, you'll be able to tell how many neutrophils you counted, how many lymphocytes you counted, how many monocytes you counted, how many eosinophils, how many basophils, and then you come up with the leukogram. So this is a leukogram. So remember the normal percentages of these white blood cells under normal circumstances, the neutrophils. So you have the quantities here per liter of blood. So it's the value multiplied by 10 raised to the power 9 per liter of blood, just like we had the area discussion. But in terms of percentages, the neutrophils should have 40 to 80%. So after counting these under normal circumstances, the value for neutrophils should be between 40 to 80%, lymphocytes 20 to 40%, then monocytes 2 to 10%, then eosinophil 1 to 6%, basophils at the least should have 1 to 2%. So the majority of white blood cells, you should have the neutrophils, followed by the lymphocytes, then the monocytes, eosinophil, and basophils. So you have the T lymphocytes here. You have the monocytes. The 2 cells are called a granulocyte. Then the neutrophil, eosinophil, basophil, these are granulocytes. And we have already looked at the different functions of these cells in detail. Okay. So still go on with the class. So we proceed. Then you can also have automated counting machines. So these automated counting machines, they are called counter. So this counter is a machine that is used to count white blood cells, red blood cells. So it will give you a lot of information. There are a lot of advantage of using this machine, despite its It's very expensive, but when you have it, it comes in handy because you don't waste much time and it's very good. So when you're using automated counting machine, it will give you the red blood cell count, white blood cell count, the differential white blood cells, and also the blood indices, like I already explained. So you have the Kuta automated heme analyzer machine. So the advantages for this machine, it's a machine. So it's very easy and rapid method. So if you have an emergency, it's very easy for you to come up with these results. You don't waste much time counting manually. It's time saving, of course, to provide additional information on the cell size, the shape, the nuclear size, density. Then very large number of cells are counted rapidly. So you're saving time to some extent. Then high level of precision. So when it comes to precision, it's very precise and accurate. And you know, to say these machines, they always have their own weaknesses or disadvantages. So what are the disadvantages of using automated counting machine? Most of the hospitals, laboratories, they have these machines that will just give instant results. So what are some of the disadvantages? So costly, it's very expensive, calibration error. Sometimes if you don't know how to use this machine, you find that you mess up with the results, and then you created red blood cells or normal blasts are counted as lymphocytes. So you not say you can have immature red blood cells that can be released to the circulation, because this machine is designed in such a way that red blood cells are only picked as cells without the nucleus. So any cell with the nucleus can be counted as white blood cells. So in general, they are counted as lymphocytes. Then platelets clumps counted as leukocytes. So if you have clumping of these platelets, that can also result into this machine counting it as a white blood cell or a leukocyte. So these are just some of the disadvantages that will come with this machine. There are more advantages than disadvantages. So these are the results that you can produce from this machine. So after processing the blood sample, you put your blood sample and then to process to give you the results. So it has got a monitor where you can appreciate the results, and then you can print out the results. So this is a printout from this machine. So you can see the type of blood tests that you have conducted. It will give you a lot of information: white blood cell count, red blood cell count, hemoglobin content, hematocrit, MCV, MCH, MCHC, all these factors. And also it will give you total white blood cell count. So you have the total white blood cell count, but on top of that, it will also give you a differential count. So it will differentiate the neutrophils, the lymphocytes, the monocytes, the eosinophils, the basophils, and the segmented ones as well. So you can find all these information. So it comes in handy. It's very good when it comes to diagnosis. So once you have the results, what will be your suspect or your diagnosis, you can easily come up with a diagnosis because you're looking at the white blood cell. If you have an increase in white blood cell count, then you can have some sort of a leukemia or leukocytosis. So look at those conditions. If you have an increase in red blood cell polycythemia, you have a decrease in red blood cell count, then you have some kind of anemia. So these results you'll be able to analyze them. So sometimes in an exam, I can just bring a page like this, and then I ask you to analyze the results, then to come up with a diagnosis. So you compare the results that you've been given with the normal ranges. So other machines, they can even give you the normal range. So you have the actual results from that patient or that person, then it will also give you the normal range. Other machines will just give you a flag, and this flag will point at where you have abnormalities. So it will do the analysis for you. Okay, enough with that. So we proceed. Let's look at physiological decussation of white blood cells. So like I said, there is a physiological decussation of white blood cells. A decussation means to crossing over. So normally in adults, neutrophil level is higher than the level of lymphocytes. So if you compare the neutrophils in adults, they are more than the lymphocytes. You know that. But now, at birth, you find that at birth, the amount of neutrophils and lymphocytes are in the ratio as in adults. So just after birth, you find that in this baby or neonate, the levels of neutrophils and lymphocytes, they are almost the same concentration compared to that of an adult person. But at day 4, day 5, there is a crossover between the neutrophils and the lymphocytes. Remember, in babies, they have a thymus, and then there is migration of those lymphocytes from the bone marrow to the thymus, where they will differentiate, and then the thymus gland will now express a lot of these lymphocytes. So in these babies, at day 5, there is a swap, or there is a decussation, whereby there's a decrease in the neutrophils and then there's an increase in lymphocytes. So later on in life, in babies, you find that they will have more lymphocytes as compared to neutrophils. Then again, there'll be another decussation. At about the age of 5 years, the lymphocytes and the neutrophils will decussate again. So they will go back to the normal concentration. So I'll explain from this diagram. So this is showing the 2-point decussation of the leukocytes in the leukogram. So you can see from this diagram here, this line shown in red here is for neutrophils. The one in blue is for lymphocytes. So you can see just after birth, the concentration of lymphocytes and neutrophils is almost the same to that of an adult. So you have an adult person here. So you can see you have almost the same concentration of neutrophils, you have almost the same concentration of lymphocytes. This is just after birth. But the 5th day of life, there is a decussation that is taking place. So the thymus is producing more of the lymphocytes, and then the bone marrow is not yet very active. So you find that the production of neutrophils is reducing here. It's something to do with the genes as well. Then after 5th day, after the decussation, you find that you have, so after the 5th day, you have more of lymphocytes than neutrophils. So in babies under the age of 5, you expect that the lymphocytes count should be more than the neutrophil count, which is very normal. So it's very important to point that when you're looking at the clinical application of these counts. So just not to say any child below the age of 5, they will have more of lymphocytes than neutrophils. Then at the age of 5 years and above, 5th year, there's another decussation, physiological decussation taking place here. So you know to say, as you are growing up, the thymus is atrophying. So the thymus will atrophy. Then the production of these leukocytes will reduce. Then the bone marrow is still very active. The red bone marrow is very active. You're still producing more of the neutrophils and a bit of the lymphocytes. So there's another decussation. So it will start increasing until after puberty, when you have the normal concentration of the white blood cells. So after 5 years, you find that these, as they are growing up, they'll have more neutrophils than lymphocytes. So I hope you understand. So there are 2 decussations. One taking place at 4 or 5th day of life, another one 4 or 5 years of age. That's why you have another decussation. So these are called physiological decussation of white blood cell. The last thing that we're going to look at is disorders of leukocytes. So like I said, this is purely pathology, so we're not going to waste much time. I'm just going to highlight so that in physiology, we're also going to appreciate pathology associated with white blood cells. So disorders of leukocytes or disorders of white blood cells. So let's start. So you can have an increase in white blood cell or you have a decrease in white blood cells. So there is a number of disorders of leukocytes. So the ones that we're going to look at in this class, mainly leukocytosis, that will result into an increase in white blood cells. Leukopenia, it means a decrease in white blood cells, and then you can also have a granulocytosis, it's an increase in this white blood cell count. Neutropenia, you are specifically looking at the neutrophils, a decrease in neutrophil count is called neutropenia. And then you can also have Chidiac-Higashi syndrome. Chidiac-Higashi syndrome it's a special type of disease. So in Chidiac-Higashi syndrome, it's a disease that is affecting mainly children or in childhood. So it's a very rare disease. It's inherited, it's complex immune disorder that usually occurs in children. So it will occur in childhood or in children. That will result into immune deficiency with increased susceptibility to infections. So there is increased susceptibility to infections. Why? There is immune deficiency in this Chidiac-Higashi syndrome, meaning that you have less white blood cell count, and that will predispose these children to infections. And it's also characterized by reduced pigment in the skin and in the eyes, a condition which is called oculocutaneous albinism. So there will be a decrease in the pigmentation of the skin in the eyes. And that condition is called oculocutaneous albinism. So that's Chidiac-Higashi syndrome. Then you can also have acute leukemia and then chronic leukemia. So these are the conditions that we are going to discuss, but we won't go into details because then that won't be physiology to be pathology. So I'll be just keeping it brief and also just to the point. So let's start by looking at leukocytosis. Leukocytosis is defined as abnormal increase in the number of circulating white blood cells. So if you have an abnormal increase in the number of circulating white blood cells, it's referred to as leukocytosis. So this is leukocytosis. So it's considered to be a manifestation of reaction of the body to a pathological situation. So it could be a pathology that is taking place within the body. Then you react by increasing the production of white blood cells. So it may also occur after exercise, convulsions such as epilepsy, emotional stress, pregnancy, anesthesia, and epinephrine administration. So these are some of the factors that will result into an increase in white blood cell count, which is called leukocytosis. So there are 5 principal types of leukocytosis. There is neutropenia. The neutrophilia, it means you have, what is mainly affected is the neutrophils. So you have lymphocytosis, you have monocytosis, and then you can have Xenophilia and Basophilia. So if you have an increase in neutrophils, it's called neutrophilia. If you have an increase in lymphocytes, lymphocytosis, an increase in monocytes, monocytosis, an increase in xenophils, it's called eosinophilia. Basophils, basophilia. So these are examples of leukocytosis. So leukocytosis is basically an increase in the number of circulating white blood cells, like I've already said. Proceed looking at neutrophilia in just a bit of information. So neutrophilia, an increase in neutrophils. There are a lot of causes. You can have physiological causes of neutrophilia. For instance, in newborn, we said just upon birth, after birth, the concentration of neutrophil is equivalent to that of an adult. So just after birth, you have an increase in neutrophil, so it's neutrophilia. Then you can, during labor, you can also have that. After exercise or convulsions, all these are physiological factors that can result into an increase in neutrophils. So it's called neutrophilia. Acute infections, certain bacilli, fungi, viruses, parasites, all these can result into an increase in neutrophil, where you have an infection. It could be a viral infection, fungal infection, bacterial infection. That will cause an increase in neutrophils. So it will result into neutrophilia. Inflammatory conditions like gout, burns, vascular disease, hypersensitivity reaction. All these will result into neutrophilia. So gout is simply a disease in which there is a defective metabolism of uric acid. So if you have defective metabolism of uric acid, it causes neutrophilia. So this defective metabolism of uric acid will result into arthritis. So you can have arthritis, why there's precipitation of uric acid that will form like chalk stones, and these chalk-like stones will start inflicting pain on the nerves. So that's gout. So in gout, you can also have neutrophilia, just like veins, vascular disease, hypersensitivity reactions. Then also intoxications can result into neutrophilia. Intoxications like uremia, accumulation of uric acid or urea on nitrogenous waste products within the blood can result into neutrophilia. Poisoning by chemicals and drugs like lead, mercury can also result into neutrophilia. Then you can also have other conditions like acute hemorrhage, acute hemolysis, polycythemia, myeloid leukemia. All these will result into neutrophilia. In polycythemia, we said it's a disorder that is affecting the bone marrow. So it's mutation of the hematopoietic stem cells and other cells. You find that they start producing a lot of white blood cells. There's also an increase in the production of white blood cells, red blood cells. So neutrophilia, you can also see it in polycythemia. Okay, so we move on. Let's look at eosinophilia. So this is an increase in eosinophils. So it's called eosinophilia. So eosinophilia is seen in allergic disorders. So allergic disorders, there'll be an increase in eosinophil. For instance, bronchial asthma, hay fever, skin diseases. For instance, skin diseases like pemphigus. You can also have an increase in eosinophil, erythema, multiform, and also scarlet fever. All these conditions will result into an increase in eosinophils or eosinophilia. Then parasitic infection, of course, where you have a lot of eosinophils, you suspect that they are parasites. So parasitic infection like malaria and also worms, then to point to an increase in eosinophils or eosinophilia. Diseases of hematopoietic system like chronic myeloid leukemia, polycythemia vera, Hodgkin's disease, pernicious anemia. Then sometimes following radiations, coidosis or rheumatoid arthritis. Rheumatoid arthritis is having inflammation of more than 2 joints. So you can have rheumatoid arthritis, which is autoimmune. It's an autoimmune disease that affects the joints. Then the sarcoidosis. The sarcoidosis is another disease. It's a chronic disease of a known cause, but it's characterized by the enlargement of the lymph nodes. So you find that in sarcoidosis, there is enlargement of the lymph node. So it's a chronic disease of a known cause, but you have enlargement of lymphoid tissue in different parts of the body. So that's sarcoidosis. So in sarcoidosis, you expect that you can also have an increase in eosinophils, which is called eosinophilia. Basophilia is as a result in an increase in production of basophils. So what can cause that? Splenectomy. Splenectomy can result into basophilia. Why? We said the spleen is involved in getting rid of the waste cells, like white blood cells or aged white blood cells or damaged white blood cells and red blood cells. So if you remove the spleen, then it means that there is no organ that is destroying these cells. So there will be an increase in basophils as well. So splenectomy, there is an increase in basophils. Then blood diseases. So blood diseases like chronic myeloid leukemia, polycythemia vera, Hodgkin's anemia, all these diseases will result into, it will point to an increase in basophils, or it will cause an increase in basophils. Infections can also cause an increase in basophils because basophils, they are also involved in allergic reactions. So you can have infections that can also cause an increase in basophils, for instance, smallpox, chickenpox, and after injection of foreign proteins. So you're talking about an allergic reaction. So you have an increase in basophils. So these are some of the conditions that will result into an increase in basophils. Lymphocytosis is an increase in lymphocytes. So you have different types of lymphocytes, B lymphocytes, T lymphocytes. Then you can also have natural killer cells, which are special types of lymphocytes. So lymphocytosis is an increase in lymphocytes. What are some of the conditions that can cause an increase in lymphocytes? You have acute infections like infectious mononucleosis. So in infectious mononucleosis can result into an increase in lymphocytes. So basically, this is also a disease that is affecting the body. So the mononucleosis disease is caused by a virus which is called EBV or Epstein-Barr virus. Then it's spread via saliva. So it can pass on from one person to another person via kissing. So it is also referred to as the kissing disease. So you can guess which group of people be affected, those who would like to kiss, because the virus that is responsible for this disease is found within the saliva. So it can spread via saliva or via kissing. That's why it's also referred to as kissing disease. That's infectious mononucleosis. Then you have chronic infections that can also result into lymphocytosis, like tuberculosis, syphilis, lymphocytic leukemia, then lymphoma, lymphosarcoma. So all these diseases can result into an increase in. So like I said, chronic infections can also cause an increase in lymphocytes like tuberculosis, syphilis, lymphocytic leukemia, and lymphosarcoma. All these can cause an increase in lymphocytes. Then you can also have hemopoietic disorders like lymphocytosis, mumps, German measles, and thyrotoxicosis. All these result into an increase in lymphocytes because they are infectious diseases or chronic infectious diseases in general. Monocytosis. So what conditions can result into monocytosis? An increase in the production of monocytes or macrophages. So even here, you expect when you have bacterial infections like tuberculosis, SEBA. So SEBA is another infectious disease. So this SEBA stands for subacute bacterial endocarditis. So subacute bacterial endocarditis is an infectious disease. Then because it's an infectious disease, you know to say there will be an increase in macrophages or monocytes. Syphilis, you also have an increase in monocytes, protozoa or rickettsia, like malaria, typhus, chalazia, the chalazia. This chalazia is also an infectious disease. The chalazia, it's a disease caused by infection with leishmania. So you're talking of leishmania parasite or leishmaniasis. So this is a parasite that can cause this disease, chalazia. Then you can also have chronic myeloid leukemia, Hodgkin's disease, multiple myeloma. All these will cause an increase in monocytes or monocytosis. Then you can also have granulomatous diseases like sarcoidosis, ulcerative colitis, collagen vesicular disease, lupus erythematosus or lupus erythematosus. Rheumatoid arthritis, all these infectious diseases, you also expect an increase in monocytes. So it's called monocytosis. So like I said, these diseases, you discuss them in pathology. That's why I'm a bit fast. Then you have leukopenia. Leukopenia, wherever you see penia, it means there's a decrease. Philia is an increase, and also cytosis is an increase. So the diseases that end with cytosis, it's an increase in white blood cells. Or philia is also an increase in white blood cells, but penia, it means there's a decrease. So leukopenia is a decrease in the number of white blood cell count, or white blood cells in general, that is found in blood. So there are different infections that will predispose you to leukopenia as well. So instead of having an increase in white blood cell, you have a decrease. So what can cause leukopenia or a decrease in white blood cells? So there are a number of conditions that can cause that. You have infections that can cause a decrease in number of white blood cells. For instance, you can have bacterial infection. like typhoid fever or paratyphoid fever, brucellosis, these conditions will result into a decrease in white blood cell count. Viral infection in rickettsia, like influenza, measles, chickenpox, dengue, infectious hepatitis, all these will cause an increase, a decrease in white blood cell count. Dengue is a mosquito-borne viral infection, so it's transmitted by a special type of a mosquito. Then the cause of this disease is called dengue. This is a virus that will cause dengue. So dengue, it's a viral infection as well. That can also result into reduction in white blood cell counts. Then protozoan infection like malaria and kala-aza, all these can cause a decrease also in white blood cell count. Then you can also have hematopoietic disorders that are affecting the bone marrow itself, or the hematopoietic stem cells in the bone marrow. That can result into a decrease in the production of white blood cells. So some of them that can cause a decrease is Gaucher's disease. So Gaucher's disease can cause a decrease in white blood cell, pernicious anemia, plastic anemia, chronic hypochromic anemia, granulocytosis. All these can also cause a decrease in white blood cell counts, leukopenia. So the Gaucher's disease, so this Gaucher's disease is abnormal buildup of fatty substances within certain organs. So there are certain organs like the liver, the spleen, and the bone, you have accumulation of fat. That disease is called Gaucher disease or Gaucher's disease. So it's a special type of disease where you have infiltration of fat into these organs. So you have splenomegaly, you can have hepatomegaly. Why? It's because you have deposition of fat, because tissues that will result into dysfunction of these organs. Sometimes if you have accumulation of fat within the bone tissue, it becomes more prone to fractures because it's a weak bone. So on top of that, it will result into a decrease in production of white blood cell. Because remember, you need a red bone marrow, but if you have more fat, then you're having more of yellow marrow that do not produce white blood cells. So you have a decrease in white blood cell count. The other cause of leukopenia is chemical agents. So there are certain chemicals or substances that can cause leukopenia: mustards, benzene, urethane, analgesics, drugs, anticonvulsants drugs. Then you have sulfonamides, antihistamines, then anti-thyroid drugs. So all these drugs, analgesics, anticonvulsants drugs, sulfonamides drugs, antihistamines, and thyroid drugs, all these can also cause leukopenia. So even as you prescribe these drugs, you need to know that some of them, they can cause leukopenia or they can suppress the immune system. So you need to take care of that. Then you can also have X-ray radiations, anaphylactic shock, liver cirrhosis, in DLE. DLE stands for discoid lupus erythematosus. So discoid lupus erythematosus is a disease of the skin. It's a common disease of the lupus family that can also cause infections of the skin. Okay, so we proceed. Let's look at cyclic neutropenia. So like I said, this is pathology. So you just need to point out what conditions can cause an increase or a decrease in white blood cells and what are those conditions. So you just need to know that information. So cyclic neutropenia, you know, to say that there is a decrease in the neutrophils. That's why it's called neutropenia. So cyclic neutropenia is a rare hematological disorder characterized by repetitive episodes of fever, mouth ulcers, infections attributable to recurrent severe neutropenia. So you have neutropenia. Because you have neutropenia, you can have infection because you don't have these cells that can migrate to the first site of infection or inflammation. Then they can't signal other cells to come to the site of infection. So you find that you are more prone to infections when you have neutropenia. It's characterized by periodic or cyclic diminution in circulating polymononuclear cells. So a decrease in the circulation of these granulocytes or polymorphonuclear cells as a result of bone marrow maturation arrest. So the bone marrow there is arrest of the bone marrow, so the bone marrow is not producing much of their granulocytes, so they will decrease in circulation. Neutropenia recurs with a regular periodicity of 21 days and to persist for 3 to 5 days. So it's just extra information to proceed. Move on to leukemia. So leukemia, in other ways, the cancer of the blood. So it's affecting the white blood cells. That's why it's called leukemia. So leukemia is a disease characterized by the progressive overproduction of white blood cells. So cancer of the blood, but here you're producing excessive amount of white blood cells, not necessarily that you're responding to infection or parasites or inflammation, but there's just abnormal production of white blood cells. So you have leukemia. It could be due to malfunction of the bone marrow, or there is plastic tissue that is affecting the bone marrow, and this neoplastic tissue is producing the white blood cells. So you have overproduction of white blood cells, which usually appear in the circulating blood in mature form. So because you are producing so much of these white blood cells, and then you start releasing them to the circulation in the mature form. So before they mature, so you have a lot of bigger cells. So you not say they will be bigger because these are immature white blood cells that are appearing now in circulation. So it's true malignant neoplasm or neoplastic tissue. So once you have neoplasm or malignant neoplasm, it means that there is proliferation of white blood cell or their precursors, which will occur in such uncoordinated and also independent fashion. So no coordination, you don't have those inducer factors or stimulatory factors. So there's just these cells that are differentiating and proliferating to give lineage of white blood cells, but there is no control whatsoever. So there will be an increase in white blood cell count in leukemia. So leukemic cells multiply at the expense of normal hematopoietic cell lines. So instead of having the normal mature red blood cell, you have a lot of these leukemic cells which are dysfunctional. Then if they are dysfunctional, then you'll be more prone to infection because you don't have the immunity to fight the infection because the white blood cells that you are having, they are dysfunctional. So that can result from bone marrow failure and altered blood cell counts. And sometimes when untreated, you find that death from infection or bleeding or both. Infection-wise, because you don't have the functional white blood cells. Bleeding, maybe there's less production of platelets. So you have bleeding disorders and also infection that can kill that person. Leukemia. So leukemia is classified into two major types. So you have lymphoid leukemia and myeloid leukemia. So the lymphoid leukemia is also called lymphoblastic or lymphocytic leukemia. That is involving the lymphocytic series of the cells. You're talking about the lymphocytes, B lymphocytes, T lymphocytes, natural killer cells, and dendritic cells. Then you also have myeloid leukemia. This is myelogenous, meaning that it's involving the granulocytes and monocytes. So the myeloid leukemia involving progenitor cells that give rise to terminally differentiated cells of the myeloid series. You're talking of erythrocytes, granulocytes, monocytes, and platelets. So this one will be severe because most of the cells are affected. Then these classifications may be modified to indicate the course of the disease depending on the time, whether it's short-term, long-term, or it's in between. So you can have acute form of leukemia. So you can have acute leukemia. Survival is less than 6 months. So it's very acute. Then subacute survival is between acute and chronic. The chronic survival is over 1 year. So if a person with leukemia can survive for more than 1 year, then that condition is called chronic. So it takes a bit of time. So the acute one, it's a deadly one that will kill a lot of patients. So certain types of leukemia show specific chromosomal abnormalities. So there is change in the genetic makeup of these persons with leukemia. So you can have mutation of the genes or the chromosomes. So you have specific chromosomal abnormalities. Chronic myeloid leukemia has a genetic alteration called the Philadelphia chromosome, which represents a translocation of chromosomal material between the long arms of chromosomes 22 and 9. So there is mutation or translocation of these materials from chromosome 22 to chromosome 9. Because of that, you know, to say the chromosome 9 is the one that is involved with the production of red blood cells and also white blood cells. So if you have a mutation in chromosome 9, that will express itself as a leukemia. So exposure to pesticides, benzene-like chemicals, ionizing radiation has been associated with an increased risk of developing leukemia. So when you're exposed to these chemicals, you can have leukemia. That's why you need to protect yourself from these chemicals. And then there are also other viruses that can also cause leukemia. So you can see here, you also have the Epstein-Barr virus, the EBV virus that can cause leukemia. Polyoma viruses, human T-cell leukemia virus, which is also called HTLV1, is also associated with leukemia. So all these viruses are associated with leukemia. So you have different types of leukemia depending on the duration. You can have acute and chronic. So acute forms of leukemia, you have acute lymphocytic or lymphoblastic leukemia. So it's acute, so within 6 months, this patient will be gone because it's the acute form of leukemia. So the acute lymphocytic or lymphoblastic leukemia is the chrono proliferation of lymphoid cells that have undergone maturation or arrest in early differentiation. So you find that there is arrest of bone marrow differentiation of these particular cells, and then there is no production of these cells. So they will undergo arrests. Because of that, you don't have these lymphoid cells that are developing into B lymphocytes, T lymphocytes, or natural killer cells. So you're going to have an acute lymphocytic leukemia, failure for the lymphoid tissue or the lymphoblast to differentiate into the mature cells. You can have acute lymphocytic or lymphoblastic leukemia. The general mechanism is the aberrant expression of proto-oncogenes, so the proto-oncogenes, chromosomal translocation that create fusion genes encoding active kinases and alteration or altered transcription factors. So you also have altered transcription factors, and then you have dysfunction of these kinases that are involved in differentiation of cells and also stimulating the cells to undergo differentiation. So there's a lot of mutation, translocation of these chromosomes from one chromosome to another chromosome that will result into leukemia, the acute form of lymphocytic or lymphoblastic leukemia. Then you can also have Philadelphia chromosome positive. So this is the Philadelphia chromosome positive is the common form of acute lymphocytic lymphoblastic leukemia that can occur in adults. This is a common form. Then you can also have acute myelogenous or non-lymphocytic leukemia. So now what is affected is the myeloblast cell, the committed cell that will become red blood cells, granulocytes, and monocytes. So once this one is affected, a lot of these cells will be also affected. You won't find them in circulation. So the acute form, you can have lymphocytes, but you won't have those cells that are coming from this stem cell or the myeloblasts. So the acute myelogenous leukemia is a heterogeneous clonal disorder of hematopoietic progenitor cells or BAST or committed cells that lose their ability to differentiate normally and to respond to normal regulatory or regulators or proliferation. So you find that those regulating substances, the inducer, the growth inducers, and the differentiation inducers, they won't have any effect on these cells. So they're not responding, and it's not differentiating into committed cells that will become xenophil, basophil, neutrophils, or monocytes, or red blood cell, or platelets. So you have less of these cells in circulation. So it's more severe, the acute myelogenous leukemia, because most of these cells won't be there in circulation. So in the absence of treatment, the bone marrow failure and fetal infections, bleeding, organ infiltration may occur within 1 year of diagnosis. So it's very severe. as compared to the acute lymphocytic or lymphoblastic. So the median age at presentation for patients with this kind of disease, the acute myelogenous leukemia, is about 70 years. So the elderly are the ones that are affected. Okay, and then there's also risk factor exposure. For instance, exposure to ionizing radiation, benzene, and cytotoxic chemotherapy. Certain diseases that are meant to kill cancerous cells or cancer can also attack these kind of cells that can also result into leukemia. The clinical features of acute leukemia is weakness, fever, headache, generalized swelling of the lymph node, petechiae, ecmotic hemorrhage in the skin, mucous membrane, and also anemia, spleen, liver, kidney become enlarged, or splenomegaly, hepatomegaly, due to infiltration of these cells. And also you can have hemorrhage because you don't have normal platelet count. So you can have hemorrhage or bleeding disorders as well. On top of that, you can also have infections. You can also have headache because you don't have enough immune cells to fight the infections. You can have headache, weakness, fever. Okay, then the chronic myelogenous leukemia. So that was the acute form. The chronic form will take a bit of time. So this is less pronounced marrow failure than the acute leukemias. There is indolent course, meaning that it will slow course, meaning that it will take a bit of time, or slow glowing some extent. So indolent course just simply mean slow glowing, or the problem is not that much. It will take a bit of time for it to develop. That's why it's chronic. Then the people affected about 55 years on average for diagnosis. The risk factors is old age or older age, of course, male gender. So male are more prone to this kind of disease, exposure to ionizing radiation, benzene containing products. So benzene is very bad to health because it can cause a lot of these white blood cell disorders. Most patients with chronic myelogenous leukemia, they actually have an acquired mutation called Philadelphia chromosome that results from translocation between chromosome 9 and 22, like I've already explained. So that will result into abnormal gene, and this gene can express abnormal types of white blood cells. So you can have a leukemia, such a case. Then you can also have chronic lymphocytic leukemia. So the one that we discussed earlier on was the acute lymphocytic leukemia. Then you can have the chronic lymphocytic leukemia that can result from slow accumulation of clonal B lymphocytes in 95% of the patients. The median age that is affected or diagnosis about 65 years. Etiology or the cause is unknown, although an abnormality with chromosome 12 is also noted. So they have an issue with chromosome 12. Then there is lymphocytosis. Lymphocytosis meaning that there's an increase in the production of lymphocytes. So lymphocytosis. So you have an increase to about greater than 5,000 lymphocytes per microliter of blood for a month. So you know to say that's an increase in white blood cell count. The clinical features of chronic lymphocytic leukemia. What are the clinical features? So the clinical features to develop insidious, or it will develop insidiously, that the disease may be present for a month or even several years before the symptoms discovery. So it's very difficult to come up with this diagnosis because there is this point in which whereby the disease is developing within these patients, but you can't pinpoint or you can't tell because it's very difficult to come up with the diagnosis. Remember, it's chronic, so it will take time for it to be diagnosed. Then anemic pallor, so there's pallor because it could be that there's reduced production of red blood cell as well in leukemia. Then the lymph node enlargement, there's hyperactivity of the lymph node, or the lymph node are reactive. So we find that there's enlargement of the lymph node because they are reactive. splenomegaly, hepatomegaly, enlargement of the salivary glands and tonsils. Then you can also have xerostomia. The xerostomia is dry mouth. So there's reduction in the production of saliva, so you have a dry mouth because of that. The laboratory findings of acute leukemia and chronic leukemia. So in the lab, what can you find with these patients with acute leukemia and chronic leukemia? So in acute leukemia, there's both bleeding, coagulation time are prolonged. So bleeding and also coagulation time is prolonged. The tourniquet test is positive. The leukocyte count may rise up to 1 million cells per cubic millimeter. So you're having more cells. Remember, the normal range is 4,000 to 11,000, but in this case, you have 1 million white blood cell per cubic millimeter of blood. So that's an increase in the number of white blood cells. And in chronic leukemia, you have anemia, you have thrombocythemia, meaning that you have an increase, you have more like an increase in platelets. This could be due to that there is a tumor that resulting into a production of platelets, and these platelets are dysfunctional platelets, so they're not functional. So this is a chronic case of leukemia. There is white blood cell count of over 5 million cells per cubic millimeter. So it's chronic. So since it's chronic, there's ample time for it to produce a lot of cells. So just know that there is thrombocythemia, and there's also an increase in white blood cell count in chronic. So both chronic and acute, you have an increase in white blood cells. So this is the cancer of the blood. So this is what you're going to find in terms of treatment. Chemotherapy, there are drugs that you can use to treat leukemias. Then you can also use radiation therapy, corticosteroid drugs. Corticosteroid drugs, you know, they also suppress the immunity. So they will decrease the production of these dysfunctional white blood cells. Then also you can give tyrosine kinase inhibitors. These tyrosine kinase inhibitors, they will inhibit those genes that are coding for proliferation of these white blood cells. So you find that those hematopoietic stem cells that are undergoing mutation, they'll be inhibited because for them to function, they need the tyrosine kinase enzyme. So if you use the tyrosine kinase inhibitor, then they'll be inhibited. Then of course you need supportive care and optimal oral hygiene care. So this is just a treatment of leukemia. So like I said, this is more pathology, and you will discuss it in pathology later on. But for now, we're going to end here. So the next topic that we're going to be looking at, interesting topic, we'll be discussing immunity. So we're going back to the functions of white blood cells, but going in detail now, looking at immunity. So the function of white blood cells, especially the lymphocytes, are the ones that are involved in immunity. So that will be lecture 7. So for now, we'll end here. Thank you very much for your time. Till we meet next time. So we'll meet next time. This is where I end the class.